Hello, and welcome to Oncology Me Podcasts, and this episode of Bladder Cancer Academy.
Good morning. Today we have our guest, Dr. Amr Shafik, Professor of Clinical Oncology at Ain Shams University. Dr. Amr, how do you classify bladder cancer?
Well, basically we start by categorizing them into three groups: non-muscle invasive bladder cancer and muscle invasive bladder cancer, and the last group would be the advanced and metastatic disease bladder cancer.
Dr. Amr, for our next question, what are the outlines for the management of advanced urothelial cancer?
Well, the outlines of the management of advanced/metastatic urothelial cancer usually is based initially on the use of systemic chemotherapy. Basically, platinum-based, and usually cisplatin would be our drug of choice. We usually use it in combination with gemcitabine, and sometimes we deter into a carboplatin-based regimen if the kidney functions would not allow to use a cisplatin. We downscale to carboplatin protocols. This was a basic understanding, or this is our basic practice that we use. Nowadays, things have been developing significantly. We have our negative studies with addition of immunotherapy and checkpoint inhibitors to the chemotherapy, either with the pembrolizumab addition to the chemotherapy or the atezolizumab addition to the chemotherapy, and they were negative studies. We sometimes, if we do not have the capacity, the renal functionality to allow the use of chemotherapy, we can use single agent checkpoint inhibitor and most probably pembrolizumab. Nowadays, things are really improving and escalating with the potentiality of using antibody-drug conjugates in addition to immunotherapy as an option for first-line metastatic bladder cancer. And also we have a new combinations that have been released. It's data in the last ESMO with addition of nivolumab to our standard of care gemcitabine cisplatin. So definitely the first line are growing in numbers. Later on, we have options that includes the use of FGFR TKI inhibitors like erdafitinib. We have also the use of antibody-drug conjugates alone, checkpoint inhibitors alone, and we can take from those options and use it even in third line according to our choices in the previous slides.
Dr. Amr, can you tell us about the rationale for using immunotherapy in urothelial cancers?
Well, the story of the use of checkpoint inhibitors in urothelial cancer was actually quite dramatic. It started with knowing that the immune evasion is one of the concepts or one of the hallmarks of the initiation of carcinogenesis and maintenance of urothelial cancer survival. And so they have started to use checkpoint inhibitors as a way of denying the cancers the possibility of evasion our immune system or the patient's immune system. So we have this data, as previously described, with the addition of checkpoint inhibitors in multiple studies, and it turned out to be negative in combination with two agents, and it was what we call kept in a solitary situation where we use a single agent checkpoint inhibitor as a first line if the chemotherapy is not available due to renal function or any form of intolerance. Now we have some data of combination of checkpoint inhibitors, because apparently it's not good enough on its own, at least in the first line. It's a whole different situation on the second line, but in the first line, we usually combine it now with a specific checkpoint inhibitor. And this is quite interesting because not all of them work. With the nivolumab, we have this positive data with a checkmate study 901. And we have also the data from the addition of the checkpoint inhibitor with the antibody-drug conjugate in the first line enfortumab. Another one of the new concepts that have been developed in the management of advanced/metastatic bladder cancer is the use of maintenance therapy. So we talk about first line, we talk about second line, but what about between both of them? Or if we can call maintenance therapy as an early second line. In this situation, we don't have data with the usage of extended courses of chemotherapy, and the only data we have is from avelumab, checkpoint inhibitors, and it can be used to sustain the benefit that you get from your initial chemotherapy, and it can affect the survival in general, in positively, of course.
Thank you for listening, and see you in the next episode of Oncology Me Podcasts.